Patrice, interested in both hearing your experience as a physician, but also your perspective with the American Medical Association.
Well, thank you. It is an honor to be here today representing the AMA, and in addition to being president-elect, I have chaired the AMA's opioid task force since 2014. And that task force was convened as a way to amplify what physicians were already doing in this area, but also to look at ways that we could coordinate our efforts and collaborate our efforts both internally within the profession and again in partnerships. And we can talk a little bit more about that in the next phase. But you ask us to reflect on today, and I would say a couple of things. I believe what I've learned as I've been chair of the task force is representative of the issue that we're discussing today. So back in 2014, I would get on a plane, I would be preparing for a talk. Folks would see my PowerPoint slides and they would say, oh, you know, you're a physician and you're working on this issue. And I would hear so many stories of family members who had an opioid use disorder. And that was the bulk of the stories. And doctor, please help. Doctor, I'm glad. What can you do? It's interesting, though, over the last 6 to 12 months or so, the question and the concern is about the lack of access for appropriate pain care and how folks are being stigmatized. We've heard that today. I've heard so many stories like Aura's story this morning. That is the third or fourth time I've had someone say that they felt like a criminal or their family member felt like a criminal when they went to get their prescription filled. So I would say my own experience is a microcosm of where we are in dealing with this epidemic and maybe some lessons to be learned. And so what I heard today, perhaps, are lessons regarding having intellectual curiosity. When there is an intervention proposed, let's be curious about that intervention. Let's ask what might be the unintended consequences. You know, we certainly needed and still need to have appropriate zeal in addressing this issue, but I think what I heard today is the importance of having intellectual curiosity, asking the questions. The other issue is the science. And I realize that science is not already there, but where science is there, let's use that science. But when there is no good science, let's state that. You know, we can say, you know what, there's no good science on this. Maybe we're going to try this, but here's what we are going to do. We are going to be committed to evaluating this intervention. And that, I think, is what I heard today. I think we have the unintended consequences that we have because of a lack of a commitment to evaluate some of the interventions that have been proposed, not only proposed, actually mandated. And I will say the last thing is about making sure we challenge, and I think I heard this morning, our own assumptions about many areas, about who has a substance use disorder, and are there implicit biases as we address this issue and so many other issues. And so that gets back to the science and the evidence and making sure we have the intellectual curiosity, but also the intellectual honesty as we address these issues. So I'll just say briefly what we recommended as far as the opioid task force several years ago. We came out with 6 recommendations. What could physicians do? And I am going to give you a little bit of context for each, and then can answer more as the questions and answer period proceeds. I will say I have to leave at 4:15 because I have to get a flight back to Atlanta to get to LA, so I apologize. I'll have to leave 15 minutes ahead of time. The first recommendation was to use state PDMPs, and yes, important, but as a data tool. When the recommendations and mandates first came out, what I heard was if doctors just check the PDMP, we will solve this problem. We all know that that is not true, but we did encourage physicians to use PDMPs as a tool, not as a panacea. We also knew that not all PDMPs were created equal. I know in Georgia, I'm in my electronic health record system, then I'm in the PDMP, then I'm electronically prescribing. And here's the other lesson learned today on many levels, but a point here is let's not minimize the impact of our interventions. It is very easy to say, go to physical therapy, try not to use an opioids, but let's peel back the onion on going to physical therapy. Going to physical therapy, transportation, childcare, time off from work. It also means you likely have insurance, because if you don't have insurance, you're unlikely to go to physical therapy. But you still may have to do 3 copays at each visit. If it's covered, and after probably multiple prior approvals. And I know, is Trent still here? I know Trent, so we'll be, but anyway, so we need to look at that issue. We certainly agree that we need to enhance our own education. The question of whether it's mandatory or not, I like what you talked about competencies, because as a psychiatrist, my training needs would be different than an internist, than a radiologist. And so these one-size-fits-all approaches we have to be mindful of and make sure that we don't continue to use blunt instruments. I will say the final thing is around stigma. Stigma regarding those who have substance use disorders, and now, unfortunately, stigma against those who have chronic pain. And that is a recommendation from our task force regarding, we have made the recommendation that we really need to elevate that issue, make sure we have a good understanding of it, and do whatever is necessary, whether that be a public education campaign or whatever, to fight stigma. And I'll just say our other recommendations were comprehensive treatment for pain and those who have opioid use disorder, safe storage and disposal, and access to naloxone. So those were our recommendations, and I think they go hand in hand with a lot of lessons learned from earlier today.
Absolutely. Thanks, Patrice.